ಫೀಲ್ ಇಲ್ಲ ಮತ್ತೆ ಯುನಿಕಾರ್ಟಿಕಲ್ ಬೈಕಾರ್ಟಿಕಲ್. Hmm. Okay. So we'll show that X-ray. Start. Hmm. 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 ಅದು ಚೀಟಿ ಬರ್ದಾಕಲಿ ಎಂ ಪಿ ಟಿ ಅದು ಇಲ್ಲಿ ಬರ್ದ ನಾವು ಅದನ್ನ ಇಲ್ಲಿ ಬರಿಬೋದು. ಪೆನ್ ಇದೆ ಎಂ ಪಿ ಟಿ ಅದು ಬರೆಯಲಿ ಆ ಕಡೆ. Registration you can do. Registration will do at what? You'll see later. Okay. Right, sir. Registration. Okay. Okay, Gospir. Okay. 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 Okay.
Camera 3 no?
Okay.
Camera 2 ಇಲ್ಲ ನೀವು camera 2 3.
Okay. 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 30 how? Okay. 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 Okay.
ट्रैवलिंग ज़्यादा नहीं हो जाता आपका? बहुत होता है.
Okay. 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 Okay.
मुश्किल है सर.
Okay.
लाइव भी देते हैं केटी सर.
Hello.
Sir,
Sir.
Ravi here.
Tell me, sir. Can you hear me?
Yes, we can hear
We
you.
started the registration.
Okay.
We exposed and we put out 2 pins on the tibia and 2 pins on the femur.
Okay.
So we are just doing registration.
Now, anything specific about the case? Like, is it
Yeah, I'll explain.
valgus, varus, anything?
I'll just present the case, sir.
So I was.
Can we have the PPT on the screen, please?
Yeah.
Yeah. See, I think your presentation you have seen. I think no. So the patient has a bilateral knee pain. Basically, right side is more than the left side, and he has valgus deformity of say almost say 171 degrees, and CPAC type 3 classification is there, and you can see here the LDFA we measured in the scanogram. It was showing 81 degree,
Okay.
and the MPTA is 90 degree. So the overall HK is plus 9 degree it is showing. So
Yeah,
this
I
is the
think
pre-op plan.
you think the valgus is in the femur.
Yes, valgus is in the femur, tibia is
Okay.
in neutral,
Okay.
and it's a pretty tight knee.
Okay.
You can see in the X-ray. I think you are sure. Have you seen the X-ray?
Yeah, not yet.
You
Yeah.
can see
Okay.
this.
Yeah.
It is the correction. The correction is in the extension. It is not able to correct. In the
Okay.
flexion, it was able to correct. And this is the values what we measure in the scanogram.
Okay.
Same thing pre-operatively we feed in the with the CT scan,
Okay.
and we did a planning in that. I'll show you in the CT scan planning later in the when doing a demonstration.
Sure.
So now I exposed it to this one. Basically the knee joint, and I put the pins and started doing registration.
Okay.
Anything pre-op plan, if you have any questions, and let me know. Otherwise,
Yeah, I think it's a straightforward valgus. You told it is clinically correctable valgus or partial.
clinically partially correctable. In flexion it is correctable, extension it is not correctable.
Okay.
Maybe I need to do IT bind picrusting.
Okay.
I'll demonstrate that and also.
Sure. Sure. Okay, sir.
Yes,
You
sir.
can go ahead then
Yes.
to the registration.
Yes, sir.
For the benefit of the delegates, we'll just show the PPT and the X-rays one more time.
Yeah. By the time they do registration, you can go ahead and do it. Yeah.
Yeah. You show the
So this is
PPT, then
Mrs.
I'll.
L.
I'll
She is a 64-year-old female who had bilateral knee pain, right greater than left. Um, clinically, she has a
okay.
valgus knee. Next slide, please.
Okay. Okay.
Next slide. Yeah. These are the
Okay.
clinical pictures.
Mm.
So it's a right knee
Okay.
that is in valgus of around 15 to 20 degrees.
Okay. Okay.
This is a walking video. Please play the
Okay.
video.
Okay. 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 I'm sorry. Okay. Oh, RMS is just 1.2.
Maulik, any
Next
sagittal
slide.
plane deformity like hyperextension?
There's no hyperextension, sir.
Yeah.
There is a mild FFD around 5 degrees, not very significant. But
Okay.
valgus is not correctable. It's a
Okay.
rigid valgus. It's a type 3 valgus.
Okay.
Okay.
Next slide, please.
Okay.
Next slide, please.
Okay.
Yeah. So clinically, like I said, there's a type 3 valgus, and range of motion is about 100 degrees. Next. Next slide, please. The bloods of this patient are all normal. There's no rheumatoid factors negative. The other tests are also normal. Cultures are all
Okay.
negative. Next slide, please.
Okay.
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 There's a significant amount of varus here. We can see that
Okay.
there's sclerotic margins of the
Okay.
bone as well.
Okay.
Next slide.
Okay.
Next slide.
Okay. Okay.
Okay.
Okay.
Next slide.
Yeah.
Okay.
So HK of around 171 and VC of 8.
Okay.
Okay. Got it.
Okay. Okay.
Can we have the video feed from the theater, please?
Okay. 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 Okay.
Sir, what surgical approach do you usually take for valgus knee and why?
This I always go by medial parapetal approach. So this is what Dr. Ranavat always to say. Don't try that lateral parapetal approach. But in a severe grade, we can do the lateral parapetalar approach. We can address the like how we do varus knee. We can do the valgus knee, so that the release and everything will be done. Only problem with the lateral parapetal approach is there's a concern about skin necrosis and wound healing. Otherwise, you can do with all the cases. We can do medial parapetalar.
Yeah, especially with robotics. I mean,
Robot.
yeah, approach has minimal. I mean, where you are planning for like fixed valgus, bony valgus, there might be I mean, there might be a role of lateral patellar. Otherwise, middle parapatellar is quite good.
Yeah.
Yeah.
So I'm just doing a registration, almost done. Meantime,
I just want to
I'll
check
just
with
teach
you
you.
how different is this registration? Is this the same like other city-based robos, or there are any different
See,
points captured here?
I think registration is not much,
Hmm.
difference. I can say there is
Okay.
always little plus minuses will be there in all the CT-based robo. The
Okay.
principle is you need to do CT scan pre-oply. Make sure that CT scan is done well,
Okay.
because if they are not done in interpretation properly, all these your values will go wrong.
Okay.
So whether you take that point, this point, at the end of the day, make sure that your CT should, your registration marks should point in collinear, or
Hmm.
it should match, and there should be, the error should be less. It is like
Okay.
a garbage in and garbage out. If your registration and pre-op planning is not good, then you end up everything will go wrong.
Yeah. Got it.
So this is I'm doing the tibial tuberosity registration.
Okay. How many
Okay,
points you registered on
I
femur
don't
and
remember,
tibia?
sir. Okay, 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 okay.
Yeah.
So once the tibial tuberosity is done, and
Okay.
then I'm going to anterior surface of the tibia registration. Okay, 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 okay,
The question from audience.
okay,
So, as it is a
okay,
completely automated robo,
okay.
so is the I mean registration is
See,
too
my RMSE is, you can see here,
okay,
0.004.
which is less
That
than
means
yeah,
there's a good registration,
yeah,
means that
good
is,
registration.
yeah. Okay, okay, okay. Yeah, your question is?
Yeah, yeah, as it is a fully automated robo,
Uh,
is I mean the registration is I think paramount here. Is that
no, no, sir.
is,
Actually, this is a city-based robo, and whether it is a you're cutting with a hand or a full automated robo, it is
doesn't
your
matter?
pre-op
Okay,
planning is very important. Where
okay,
your, this is also haptic boundaries are there.
okay,
Make sure that within the haptic boundaries are there, robo will not cross that line.
okay,
Right.
okay. Understand.
So I'm just done a registration. Now I'm going to show the balancing part. So
Okay.
in extension and how much it is correctable or not. So this
Yeah.
is in extension. You can see there's a medial axis is around 9 millimeter. That is 10-degree valgus deformity,
Okay.
and it shows 10-degree flexion deformity. But the sagittal sections I don't consider these robos, because there's always variation in the posterior axis in all the robos. So
Okay.
clinically it looks pretty straight, but it shows 5-6 degree always valgus. So now with the laterally, it was medially it was 9, and you can see this correctable is almost 5. Maybe slightly the IT band tightness is there. I can do IT band precasting now in the beginning itself, so that
Okay.
this is after the giving a virus stress. After correction of this much, you get almost, you are able to, this IT band precasting can be done now, or later also we can do. Now you can give a knife here. So I'll just do ID band precasting, so that I can reduce my error in bone cuts.
Okay. So just for audience sake, how do you identify IT band and what?
So IT band is the lateralmost structure just below the patella. It is attached to the Gerdy's tubercle,
Okay.
and like Dr. Anawat paper has mentioned is that, so make sure that you give a valgus stress
Okay.
and find out that this is a dense tight fibers, feel it, and that is the most lateral structure is tight structure is the IT band.
You just puncture them. Yeah.
You do multiple puncture,
Yeah.
very tight here.
Yeah. Now you want to reassess after releasing how much
Yes, sir.
valgus you are able to correct. Yeah.
Yeah. Light adjustment. So I did the IT band track resting, still a little more tightness is give the knife. Hold it. So now see you can now it is 9 on the medial side. You
Okay.
can see that the lateral side is almost, see I am able to match to the similar
Middles.
to the 9. I should get a little more. Maybe
Okay.
the once the tibia is I
Yeah.
think the lateral side is still tight
Correct.
around
Correct.
6. But if we give valgus varus stress, it is almost say correctable.
It
Whether
might.
it is my leg
Yeah.
is going a valgus or not, you have to see.
Hmm.
It is not going backwards. That means
Okay.
dynamic structure is not happening. So
Yeah.
once you cut the tibia, we should able to match, or maybe with minimum resection, release, we should able to
Partly,
achieve.
partly it may be due
Now,
to tibial defect as well.
yes.
Yeah.
So yes, that's the reason I am not
Mm.
doing completely now only.
Okay.
So now it is all almost it is they say 1 degree or only tightness you can see. The medial side is 7, lateral
Okay.
side is 6.
Okay.
Okay. So
Yes.
now
Yes.
that I'm just accepting that it may be because of tibia or not, we'll
Okay.
judge further fine tune it later.
Sure.
So now I'm flexing the this one. You can see here it is almost balanced here. In
Okay.
the medial side is little laxity is there, and lateral side is 8 mm tightness is there.
Sure.
You can see here the posterior medial cut is 8.5
Okay.
and the lateral side is 7.2. So
Okay.
we are resecting more on the medial side.
Okay.
So we have kept the extrudation of 2 degree in the before surgery in the CT scan, and now we are going to little alter. That is, I
Okay.
use the surgical epicondylar axis as the rotational landmark. So according to the 2 degree extrusion was there. Since there is a medial laxity is there, and I am changing my the component to 1 degree interrotation.
Okay.
So can you rotate medially 1 degree? So now if I give the stress again, still it is not opening up much. So
Okay.
now it is 8.1 and 7.6. One more degree.
See 8 and 9 now inflection.
Yeah.
Okay.
So now almost you can
Yeah.
say still 8 and 9 it is there. Maybe I have to see that popliteus is tight or not. You know what?
Maybe after the cuts and little bit of removal of osteophytes, that should take care. I think.
Yeah, that's what.
Yeah. Yeah.
So you can see now it is almost when I give algal stress it is correcting almost 0. So 8 and 8. Okay. So this is in 110-degree flexion, and mid flexion you can see here I'm just gradually from complete flexion to slowly extending it, whether the mid flexion is there or laxity is there in either side. So still if you see laterally still tightness is there. So
Tight in mid flexion range
yeah,
and
tight
balance.
in still lateral side is tight is there.
Yeah.
So maybe that maybe because of osteophyte or not, I have to see.
Correct.
Or
Correct.
still on IT band tightness, I just see and do that once again.
So other than 1 degree of internal rotation, you are not changed
Scissors, bro.
anything, no? Right now.
See, sometimes with the lateral parapatellar area,
Hmm.
the retinaculum is very tight. So you
Correct.
need to release that so that automatically. In 90-degree flexion, able to correct it.
Yes, sir.
In the only the mid flexion, it is little tightness is
Tight
there.
under.
This is an IT band only.
Yes, sir.
So,
See,
microst knife, bro.
you want to
Yes, sir.
balance everything before the.
No, I just try to
Yeah.
do minimum as much as I can, and later the
Yeah.
defect is if it is not much, See,
Okay.
I'll just show you the defect here.
Okay.
So I'll show you defect.
Sure.
Moments. So defect is, I'll just show the moments, could you? What question is see, the defect is not much, there is a minimum defect is there.
Okay.
So according to you, what you said is right.
Yeah.
So once the bone cuts is done, then only the left out again we have to do with the soft tissues. So
Okay.
I'm just thinking whether we are able to correct it as much as I can before
Yeah, before
bone
the
cuts,
cuts itself.
so that we can always adjust with the bone cuts, so that we
Rajshekhar sir,
don't
what
want.
all the recommendation you do? Like for example, you want to balance this valgus knee.
So
So
it's
what are the
basically
strategies
the,
you have?
see that you know always I follow the runout protocol,
Okay.
whether it is a balance in extension and balance in flexion.
Okay.
So in extension, if it is tight, most of the time it is an IT band and the posterolateral capsule is the tightness is there,
Okay.
and along with the bone cuts.
Okay.
So once you do the tibia and the femur,
Hmm.
then you balance in extension. That's what you do conventionally.
Correct.
Here is the advantage of robo is that the values are showing already here. So
Okay.
if I cut this much tibia on the lateral side 6 and medial side is 5.5,
Okay.
and on the femur 8 mm on the medial side, 1.8 on the lateral side,
Hmm.
it shows that my, if you see the varus stress,
Yeah.
stress, it is medial side is 9 is opening,
Okay.
and the lateral side it is 7. That means still some amount of remnant of IT band tightness might be there, or
Okay.
posterolateral capsule is there. I have to see.
Okay.
This much I can do later also. The posterolateral corner I can't access now.
Okay.
After cutting the distal femur and proximal tibia, I can do.
I think
In
so.
this robo, advantage is that
Hmm.
once you do the femur everything,
Hmm.
I can do fine tune balancing also.
Correct.
That's why make sure that in this case, in this particular design, especially uh, we cut the bones and then we balance later. So
Okay.
like Leo White side.
Okay. So
So almost
yeah,
flexion is
that's
completely
what I have.
balanced. Only I have little tightness is in the mid flexion. Okay. With this, I think I can go to the bone cuts.
Okay. So
Right,
now
sir.
the
Any questions, sir?
question is like how much valgus you accept? It was 10-degree valgus. Do you want to get it to complete neutral, or you want
So I'm
to?
getting it a zero neutral.
Okay.
In this case, it was 7-degree pre-op CT scan planning was 7-8 degree was valgus was there.
Okay.
I think 171 degree was there.
Yeah, 171 was the.
187 is the HK.
Okay.
So I usually do within the 3 degrees. I try to get it
Okay. Within
without
3 degrees border.
compromising the ligaments.
Okay.
Right. So now I have done registration, did the preliminary balancing.
Okay.
Now you are fixing the, here in this, the advantage is there is not an handheld. We have to fix the robot to the femur.
Okay.
We have external fixator. This can be fixed with the external fixator to the robot to the this one.
Okay.
Or we have 2 pins in the femur, 1 pin on the femur, 1 pin on the shank pin on the tibia.
Hmm.
Then we can fix the robot to the arm to the femur,
Okay.
to the human body. So we are putting an external fixator, you can see here.
Hmm.
This is the external fixator, show that it is axially moving, but
Okay.
there is not
Yeah.
complete, is not loose.
Correct.
So with
correct.
this is good enough for the robot to fix it now.
Okay,
Getting the
understood.
robot nearer.
So while robo is set in, what all the precautions we have to take, as it is a completely automated robo?
See, they said this pre-op planning is very important. You have to see the CT scan. Where is your bone cuts are going?
Okay.
Since it is a CT scan and it also have the field is there.
Okay.
You have to follow. It will be in the same range if you have. Especially in the medial side, MCL should be taken care.
Okay.
Lateral side, the patellar tendon should be taken care.
Hmm.
Posteriorly, if you are a CR surgeon, PCL should be there.
Okay.
And if you are too much go posteriorly, that definitely vessels will be a risk.
Okay.
And anteriorly, femur is anterior notch will be the problem.
Okay.
So you have to be careful. And especially the box cut, when you're doing a box cut, you have to be careful. You have to flex the knee, and the vessels should not be coming in the way.
Sure.
Be careful about it. I have not seen that, but this is
Yeah.
the precaution. And
Yeah.
medially, when you're preparing the peg, this is sizing is we have to be careful.
Sure.
So this is very thing. And when the robo is cutting it, you can the handle can touch the patellar tendon. That's
Okay.
why I'm averting the patella, keeping it. Otherwise, if you invert the patella,
Hmm.
that robo handle will go and rub the patellar cartilage, that
Okay.
can damage the patellar cartilage.
Oh, understood, understood. So, I mean, I just wanted for further clarification. So, is this robo will, I mean, robo software will show like whether we are notching or we are inflection, or whether we are
There's a
oversizing.
pre-op CT scan we can see.
Okay,
In that we can properly do it. Then
okay,
in this actually they're showing it is can't make out actually very difficult to say
okay,
intraoperatively. It's
sure,
only you can observe and you can immediately stop the robo.
okay,
It automatically stops.
sure.
So now I have fixed the robo to the external fixator clamp
Hmm.
and what happened? So you can see there is a robo approach here. Yeah. So this is you can see the screen where is the rope.
Yeah.
Okay. This is the robo approach you can see in the screen.
Hmm.
So where there is a bone angle and there is a robo angle. You should be usually in the blue and green. Should not be go beyond 20 degree 20 number. That means it is not acceptable. So now I am confirming it again with before already we have done it again whether position is okay or not. We are just confirming with this one. So we are checking the point or marker point to the robot to the bone and to the patient. So now it is accepting now. So now before cutting the bone, again we have a checking points on the again femur and tibia like legural other systems. So we are checking on the medial side and on the lateral side. So now it is, you can see now it is how much you can see here on the femur, how much it is cutting is showing here. You can see in the screen how much cut in the femoral side, distal femur. You can see on the mid lateral side you are not cutting much.
Correct.
Okay. So similarly it shows every this one. This is the yellow line is that the robo is will be within that range so
Okay.
that it is not violating beyond that what you are. So you can see the robo is now that is cover ilva?
It's going. Hmm. Actually, it's, I mean, more of,
My
yeah.
the distal femur cut is done now.
Okay.
So we can remove the remnant cartilage, bone, and everything. You can see there is a nice the distal surface is formed on both medial laterally. So now it's going to be cut on the anteriorly.
And if you do a proper planning, while the robo is cutting the femur, we can finish on conventional surgery and other OT and come back.
Yes, conventional surgery is always faster. Then the whole day of conference is not there.
No, no, no. The software is, I mean, that is the advantage of technology. Like, if you are confident and if you're trusting the system, so much of
I
advancement can
can't
be
hear
done.
you.
No, that is the technological advances what are happening. Like in the future, I mean, if the accuracy levels improves and if there are no errors, that can also be done. Like after we set the program, we can leave the robo for cutting and we can do some other work as
Yeah,
well. Yeah,
but then only always is the pre-op planning is very key,
yeah, yeah,
and the again now it is all AI technology,
yeah.
and how much your software you are, already you loaded inside that robo or computer or pre-offline AI technology is there. It
Okay.
all gives you the feedback. So at the end of the day,
Surgeon is the
the
king.
surgeon's perspective is very important here. Your experience and what works in your hand, accordingly you can choose. So there,
Okay.
since there are so many techniques which has been alignment philosophies are there,
Correct.
and we all still feel that extreme kinematic alignment, extreme any alignment is not good. Again, you have to be within 3 degree. Sort of a balancing the knee is very crucial.
Okay. Rajshekhar is little away from the field. Everybody that under field. Yeah. Robo, you're not able to see. Yeah.
Yeah,
Okay.
we can
Okay.
see here the
Yeah.
anterior
Hmm.
notching is there or not. We can feel here. We can
Okay.
anytime we can stop. So a lot
Okay.
of people feel that it is anterior notching is there or not. We are not doing any notching. We can proceed.
Okay.
Now it is the anteriorly done. Now anterior chamfer, anterior cut is done. Distal femur cut is done. Now we are going to cut the posterior chamfer.
Okay.
And this is where your medial side you have to be careful. I am putting a homons on the medial structure,
Okay.
just safer side. So, but again, you see that yellow mark is there. It will be in that only. So it will not go beyond that, and it will be very sensitive to patient movement or the this one. So not to get worried with any, not to get scared. So
Okay.
make sure that you plan it well, and I don't think you should worry. In the beginning, I also have a lot of fear,
Okay.
and I used to here and there, but I not any seen any problem at all.
The key is preoperative planning.
Yes, yes.
Yeah.
So this is where I was telling, if the patella is inverted, then the
Okay.
robo hand will come and touch the patella. That's why
Okay.
I'm averting the patella, so the patella cartilage will not get damaged. So now I'm going to cut the posterior. Chamfer is over. Now posterior cut.
Okay. Any precautions you have to take here, sir? Postercondylar cut. Any precautions like
You're telling something, sir?
any precautions you have to take during this cut, the postercondylar cut, to avoid neurovascular injuries or like you have
No,
to.
in the sound I can't hear you. Can you speak little louder? Ravi?
Yeah, yeah. Any
I
specific precautions you have to take during the postercondylar cut to
No,
avoid
nothing
neuros?
actually. Except as I told you,
Yeah.
avoid the patella, lateral structure will be avoided. Medial side when you're doing, you
Yeah.
put the omens,
Okay.
so that MCL will not get damaged.
Okay.
And don't oversize the femur,
Okay.
oversize the tibia.
Okay.
Otherwise, this according to the ectoic the field, it will come out of your field. So that make sure that it will be within that sizes.
Okay.
Then will not be any problem. Now I am cut the posterior condyle, and now it is going to cut the box cut,
Box. Yeah.
lug holes and box cut. Bus. Wait. Wait. See here, sometimes there is a small bleeder comes from the genicular vessels, but
Okay.
very rarely. The
Oh,
synovium structures you can see here,
okay.
nothing actually. So done nothing. Proceed further. Next
So
we have to
we can
actually
stop
flex.
anytime.
Huh.
That's the
Next.
advantage.
ಏನಾಯ್ತು? Huh? Nibbler ಕೊಡು. Nibbler. You can go to that next. Go and continue that. Sometimes if the bone is stronger and burr is a little blunt, maybe, or sometimes if the bone is very hard sclerotic, it
Yeah.
will not proceed. Done, I think. Continue, Vega. Stop, finish that. Bas, bas. This is the last cut of the femur. This is called anterior, where there is a flange type of surface is there. Just a small that
Patellar
cut is done.
sulcus.
So now the femur cut is done.
Hmm.
Now we should go to the tibia. Again, you confirm the registration point on the tibia. Again, in the medial side, protect the MCL.
Yeah. Cameraman, if there is an option of focusing camera from the top, can you
Can you
please?
speak little? Can you speak louder, sir? I can't.
The cameraman can focus from the top, sir. Can I mean,
Can you focus on the top?
yeah, so that we can see the tibia
No,
cutting.
sorry. Oh,
Yeah.
okay, sir. Hi, sir. Can you sir? Yeah, I can see now.
Yeah, you can see.
Sorry.
Yeah. Go to lateral now.
एक मिनट let it go. पूरा आंख में खुल जाता है.
Sorry.
Now the tibia cut is done. So now I have to remove the osteophytes. While I'll remove the osteophyte and I'll come back to you. You can till the time you can discuss something and then I'll remove the osteophyte and I'll show the balancing.
Sure.
Great. Hmm. So I'm disconnecting the robo handle and robo external fixator
Okay.
and everything.
So including that foot pad also you removed.
Foot pad is very cumbersome. We are used to that your conventional way of holding
Correct,
the leg.
correct. Now the left foot job is to remove the
Remove the left out osteophytes, the remaining bone,
okay,
and reshaping and remove.
and
So the
trialing.
tibia come. Once.
Yeah,
Table down.
may not require also after we remove the tibia along with some soft tissue would have
Nibbler.
already released. Cameraman, can you focus on the knee,
Osteotom.
the right side image or a video?
Yeah, correct. Straight illa. Nibbler kodu. Nibbler.
ಹೌದಾ ರಾಜಶೇಖರ್ ಸರ್
Sir.
ಅವ್ರಿಗೆ ಕ್ಯಾಮ್ರಾಮನ್ ಅವ್ರಿಗೆ ಈ ಸೈಡಿಂದ ಫೋಕಸ್ ಮಾಡಕ್ಕೆ ಹೇಳಿ ಸರ್ ಸೊ ದಟ್ ಯು ಕ್ಯಾನ್ ಸಿ ದ ಲ್ಯಾಟ್ರಲ್ ಕಾರ್ನರ್
From this side.
yeah
Middle
from
side.
the medial side he can
Yeah,
focus
yeah. From
focus
here,
this,
focus.
yeah.
Saw kodumani. Osteotom. The last corner of the bone I have not removed. So with the robo, I'm
Okay.
just doing it so osteotom and say saw.
Okay.
So the left bone will be have to be done with saw only or osteotom, based on the depending on the how much you.
The posterior lateral corner bone.
Yes. Posterior lateral, posterior medial,
Hmm.
where you feel your safety is required. You
Okay.
don't go beyond that. So Omans. Saw. Omans. Omans. Saw. So I'm just cutting with the saw here, this last corner of the bone.
Okay.
This is where your safety. I'll shoot him. So, I'll shoot him.
Time we are going home 2 घंटा लगेगा अभी 4 घंटा लगेगा मेरा पेट्रोल खत्म ना हो जाए मैं सोच रहा हूँ
See femur cord. Deal है ना?
तो अभी हॉस्पिटल जाएंगे राउंड्स करेंगे
So good. कट्टा है.
कल का पैकिंग करना है कल की सर्जरी करके सर्जरी खत्म करके घर वापस मैं एक भी अभी फोटो देखने
Posterior osteotom. So the posterior osteophyte you need to remove.
yeah
So curved osteotom.
maybe the tightness was due to that yeah
Yeah.
a little bit 2 mm tightness.
Disaster. Can you see here, Ravi?
Yeah, yeah, I can see
See the
now.
posterolateral bone still
Hmm.
left out. So your
Correct.
robo is not going beyond that edge,
Correct.
and it is not going to violate your neurovascular structures. You can see here.
Correct.
Yeah.
So that bone you are showing it now? Oh, you already removed it.
So my tibia is prepared well.
Okay.
So you see always if you're doubtful about tibia cut, if you're not worried about a tibia cut, you can always cross check with a conventional jig. Tibia jig is there? Illa, illa, right? Illa open ಮಾಡ್ಬೇಕು better. ಫಸ್ಟ್ ಟೈಮ್ ಕೊಡು ಈ ಕಾರ್ಡು ಓಪನ್ ಮಾಡ್ಬೇಕು ನೀನು ಮಾಮೂಲಿ ನೀವು ಇದಿಷ್ಟು ಹಾಂ curate. femur ಕೂಡ right tibia ಕೂಡ jig. So now you can always reconfirm. You can say if you're whether you cut or not. I see my tibia cut with the jig. You are almost say center.
Yes, yes. You can
Okay.
see that. Yeah.
So this is how it is. From here you can do from here.
Now
Femur.
trialing. Yeah.
See the saw ಕೊಡಿ. Not wrong. See, this is what burr is. If it is very sclerotic bone, sometimes it just don't cut it. So there may be some to reshape it. चल femur D ಕೊಡಿ. Punch. Sitting very well femur. So you can see here. You can zoom it here. So there is no notching anteriorly. Middle laterally sitting well, and it is very well fixed. Okay. Can you hear Ravi?
Yeah, yeah.
Oh,
Very nicely
yes,
fixed.
sir. Right. So now my flexion is balanced.
Okay.
So my extension I'm able to correct completely. You can see here.
Yeah, valgus is completely corrected. Can you see on the
I'll show you robo, sir.
yeah, yeah, on the screen?
So please you take out because it's coming in the way.
Clinically, it looks nice. Yeah.
See here, medial-laterally balanced.
Okay.
11, 11.
Okay.
Okay. It's equal.
We are not able to see the screen.
Screen can show their screen here. Okay. Right, sir?
Uh, Not able to see the screen yet. Yeah.
1 second, sir.
Okay. Yes.
So you can see mediolaterally equal.
Yeah. Perfect.
And the limb alignment is 0 degree.
Okay.
Okay.
Yes.
So this is in extension. And
Okay.
flexion, you can see here
10
almost
each.
10 10.
Very
My
nice.
patella you can see here tracking well, even though I rotated internally 1 degree or 2 degree.
Okay.
It is almost sitting very well.
Very nice.
Right, sir?
The yeah, overall alignment is 2 degree valgus, limb valgus.
No, it is in extension 0 degree.
0. Okay.
In flexion it was showing is 2 degree, but
1
in
degree. 1
flexion
degree.
is not
Yeah.
1. Okay,
The
sir.
and the extension, sir, full extension or
Full extension is 0 degree.
Okay.
Show that. Focus on the screen.
Yeah. Okay.
Okay.
Yeah, fantastic, sir. Very
Right,
nice.
sir.
Very nice.
Thank you, sir.
So we'll
Well, yeah, sir.
break
I'll
up for
cement
the
and come, sir.
yeah, we'll break up the workshop for
Sure, sir.
workshop. Thank you for excellent demonstration,
Thank you,
and
sir.
it was a very good case. Valgus. Thank you very much once
Thank
again.
you, sir. Thank you.
As we come to a close to today's CME, on behalf of the organizing committee, I'd like to express our heartfelt thanks to all the esteemed speakers who have generously shared their expertise with us. We are also deeply grateful to all the attendees for gracing us with your presence. Your engagement has made this event a truly valuable experience. Thank you once again to everyone for your time. With that, Robocon 2025 comes to an official close. We wish you all the best. Thank you. We will have the workshop starting shortly at 5 p.m., where you can get a first hand experience using the robotic systems. There are 3 different stations, one each for Mako, QVIS, and Cori robotic systems. I request all the delegates who have registered for the workshop to make their way to the hospital building next door after the closing ceremony. The workshop will be conducted in the 3rd floor of the hospital. There will be signs guiding you towards it at the 3rd floor. At each station, we have a list of candidates enrolled for the particular robotic system station at the time of registration. So the delegates can be at the station where the name is listed. Thank you. To the delegates who have registered for the workshop, kindly wait at the entrance. We have someone to guide you to the hospital there.